Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Aleksander Vitali, a functional and pediatric neurosurgeon practicing in Saskatoon, and Dr. Jonathan Norton, a PhD neurophysiologist also practicing in Saskatoon, discuss functional neurosurgical procedures and the impact of anesthesia on these procedures. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Thank you very much for inviting us to talk about neuromodulation and how it relates to anesthesia. So I will start. My talk is more practical, and then Dr. Norton will take over. So I'll concentrate. I'll show you what we do, a list of neuromodulation procedures. We'll explain if we do it one or two stage and why, and then do we want the patients to be awake or asleep? And then I have one or two slides for practical point. So our neuromodulation program started actually in 2005. Dr. Griebel, those who have been here long enough will remember him. He did a couple of spinal cord stimulators and intraoperative pumps. And when I started in 2007, I inherited about 20 patients, about 10 each. Then Dr. Norton joined us in 2013, and we also had Dr. Mendes for 10 years. The end result is now we have about 650 active neuromodulation patients, and every year it increases by about 30 to 40 new patients. This is the list of procedures which we do currently, and I am part of neuromodulation group in Canada, and we are unique in the sense that we do all of this here in one place. In bigger centers, they may have more surgeons, they have more bigger number of patients, but they usually subspecialized. There's someone doing only deep brain stimulation, someone doing only pumps, for instance, someone doing in BC, there is a different person who does pumps for pain versus pumps for spasticity. So let's go to specific procedures, and we'll start with the spinal cord stimulation because it's the most common surgery which we do. Those are the indications, and they're highlighted in, sorry? Oh, okay. Those are the indications, and the highlighted ones have the best results. It's traditionally, spinal cord stimulation has been around 30 years now. So it's at least 80% success rate. And actually the vascular pain is even more successful. Some people say 90%. For some reason, we don't get a lot of referrals. So most of you probably have seen it already. After a couple of bad experiences initially, we started doing it always under general anesthetics. I tried to do percutaneous electrodes with local anesthetics and some sedation. Patients were usually not very cooperative. Chronic pain patients, about 1/3 of them will not be able to lie still in prone position. That's my experience from trying to do it on the local. Then we would implant the electrodes, cover the hardware with a dressing program, send the patients home for 1 week. And if their pain was reduced by half and they like the stimulation, we would bring them in and implant on the second stage. So has been more and more evidence over the last few years that actually most patients get implanted anyway, so why won't we do it in one stage? Those who remember, Dr. Mendes used to do it in one stage, but that increased a little bit number of revisions. But then we looked at our patients here, and traditionally we had about 80% implant rate. In 2023, our implant rate was 88%. And last year, we did 26 trials and we implanted 24 patients. The 2 failures were in the same patient who had pain because of previous tumor surgery and because of the scar tissue. We couldn't get the electrode where we needed. We tried from below, we tried from the top. So both failures were in the same patient. Then I also looked at the cost of OR, and it wasn't clear. Now it is. 1 bigger surgery is cheaper than 2 smaller surgeries. And it is not only relating to staff, but also surgical time. So the first stage usually will take us about an hour. Second stage will take us 20 minutes to 30 minutes. But with the changeover and anesthetic time, it accumulated to about 4.5 hours for those 2 procedures. If we do everything in 1 stage, we are done within an hour, hour and a half. So even with the changeover time, it's basically half. And that's, at the moment, that seems to be the only way we can do more surgeries because of problems with OR time. Also, because of the MRI compatibility, we started implanting batteries in the buttock area, so we don't have to turn the patient, we don't have to reposition. So the 4 highlighted surgeries with a high success rate, we started earlier this year doing in 1 stage. And we have maybe 1 revision so far, but most of them doing well. DRG stimulation, dorsal root ganglion stimulation, it's basically a form of spinal cord stimulation. It's just a different shape of electrode and is placed in the foramen. So simply because we don't do enough of those, it only became available in Canada in 2021. We've done about 10 or 15. We're still learning that. My biggest problem with this is that it's not MRI compatible, so I do very few. Once we have more experience, again, the highlighted ones, those are the best indications. We'll probably switch to 1 stage. The pelvic and groin pain is difficult to treat. Like this is probably the best modality to treat it, but there's still controversy on what's the best position of the electrodes, L1, L2, or sacral. So as we get more experience, probably you will switch to 1 stage as well. Peripheral nerve stimulation, those would be the indication. As you can see, most of them are limited to the head area and smaller region of pain. So we do it in 2 stages because most patients actually probably have some combination of those diagnoses. It's difficult to figure it out. So we implant the electrodes under general anesthetics. This is intraoperative picture where the instruments are. Those are patients' trigger points. So that's where they show where the pain is the worst. We mark it. I only give local anesthetics at the point of stab where I put the needle, because if I inject along the electrode, we can't program those patients. We would have to send them home and bring them other day. So I need them under general anesthetics. That applies for peripheral facial stimulation, occipital stimulation. So it's done in 2 stage trial first, just electrode. We give them 10 days, 7 to 10 days, pull the electrodes out in the clinic. And then if it was working well, we bring them back for full implant. So electrodes and battery. Deep brain stimulation. Those are all options for DBS, and except for pain, we've done those surgeries here. Dr. Mendez used to do a lot of psychiatric DBS. I think we've done 5 epilepsy DBS surgeries as well. So it started awake 20, 30 years ago because we wanted to monitor patients. But with the time, again, it became obvious that with better targeting, reliable stereotactic systems, we almost never reposition the electrodes. So first we started doing patients with dystonia because they couldn't stay still anyway for under general anesthetics, then Parkinson's disease, because we got pretty good results. We didn't have to test for rigidity or tremor anymore. And then last, essential tremor, because VIM stimulation can cause problems with speech. But now we have a way of monitoring that as well. So this is the last part, this is the last type of DBS which we switched to asleep. We've done 2 or 3 this year with the good results. And it's tremendous improvement for patients, because before, when I told them in the clinic, oh, your head will be screwed to the table for 4 hours, you will be awake, 1/3 immediately was not interested. So, unless we had, in the last 12 years since we started doing DBS, we had 1 patient we were not sure what type of tremor it was. So therefore, we were not sure about what was the best target. We did it in 2 stages. We put the electrode, admitted the patient for 3 or 4 days, and then did the stage 2 later that week. But basically, 99% of the time, it will be 1 stage. And again, unless there's unusual patient and we need to monitor something, it will be almost always asleep. Motor cortex stimulation, you haven't seen many of those. We've done only 2. This is basically 5-word summary. We would do usually in 1 stage, because those would be a patient where we have nothing else to offer, and we don't want to risk an infection in subdural or epidural space. So we probably would just implant everything. And then if it doesn't work, we may bring the patients later for removal, but they always would be asleep. Gasserian ganglion stimulation, the last thing which we added. So that started with radiofrequency rhizotomy. Those who are here more than 10 years may remember this was the worst surgery. Anesthesia hated it. I hated it. You can imagine the patients. So when we started under sedation. So anesthetists would sedate the patient to the point the patient stops breathing. And then they do something, stimulate, put your needle, we need to stimulate the patient. So I would put the needle with X-ray guidance. Once I felt that the needle was in place, we had to wake up the patient to the point now the patient's supposed to communicate with me. So we would stimulate and ask the patient, where do you feel it? In your forehead, in your cheek, in your jaw? And once we figure it out, again, sedate the patient to the point he or she stops breathing, then anesthetist, okay, lesion, you need to stimulate the patient. We would lesion, then wake up the patient, again, wait 10, 15 minutes until the patient can tell us, and then I start poking the face. Does it feel sharp? Does it feel the same on both sides? Those procedures would take 1.5 hours. Anesthetic, depth on anesthetic would be like this, and everybody hated it. So when Dr. Norton started, we started doing it with monitoring. And from that, we switched to actually implanting the electrodes. It's the same procedure, just a bigger needle. And then we have 8 contact DBS electrodes, which is actually perfect because it's perfect fit for Gasserian ganglion. So we have like 2 or 3 contacts in each branch. And then we implant it. And on X-rays, it looks like this. But X-rays are unreliable because everything depends what angle the X-ray is done. So I'm relying only on monitoring. Like we do X-ray just to get the electrode in place, then I don't bother. Tunnel the electrode and recheck it that the same contact is still stimulating the same part of the ganglion. So it is 2-stage because it's a new procedure. We've done only about 8 or 9, but except 1 patient, all did very well. And of course, asleep. Vagal nerve stimulation, there's nothing to monitor. We do it for seizures and depression. We do it always under GA, always 1 stage. Many of those patients won't cooperate. Pumps for cancer or spasticity or non-malignant pain, always 1 stage, always under GA. We do the trial in the ward. So we put intrathecal catheter, give them medications. That's how we decide if it's a good candidate or not. Once we bring them to OI, it's just for an implant. So the last 2 slides. So basically that's all what we do. And you can see that some we do 1 stages, 2 stages, but basically everything asleep. For implants, now everything is asleep. You may ask, what about the smaller procedures like battery replacements? Well, we can do them awake or asleep, but some patients can't stay still. If you have a patient with dystonia, turn the stimulation on, or patients with Parkinson, with dyskinesia, they may not be able to lie still. Bed tremor, the same. Some patients can't cooperate. Many patients with vagal nerve stimulators, they have some mental handicap, and you can't make them cooperative. And now with most batteries placed in the buttock, many patients won't be able to lie prone even for 15 minutes procedure, and lateral position is not always good. Battery repositioning, always under general anesthetics, unless I'm just flipping the battery. So say the patient wants the battery a little bit higher, we can use the same incision and move battery from below the incision, create the pocket above. For that, I can do under local, but anything else will require tunneling the cable, so it has to be under GA. Spinal cord stimulation revision, always under GA, unless it's a percutaneous electrode, and we need to just pull it down a little bit. This is the case we did last month under local anesthetic. It actually worked very well. Pump replacements can be done awake, but remember it's a metal hockey puck, which we have to deliver from the pocket. Some patients may not like it, but it can be done awake. But pump revision, GA, because that usually involves tunneling the catheters.
Going to cover some of the same ground that Dr. Vitali talked about. When we talk about electrical stimulation, we'd like to think that about a milliamp of current is going to travel a millimeter of distance. So if we're going to stimulate a structure, we need to be reasonably close to it. I'm not going to talk about intrathecal pumps or sacral stims. Sacral stims done by urology, and that's nearly always done asleep. And they look for the bellows in the anal sphincter. We can talk about the same procedures. Why change to sleep? So a couple of reasons for doing this sort of stuff asleep. One is that the patients seem to like it. Got to remember that these are typically older patients. They have other things going on in addition to the procedure we're treating. So, you know, once you get into your 60s, 70s, you're thinking about patients who have hip pain, neck pain, back pain, in addition to whatever it is that we're going to try and treat. And then there's evidence that it is somewhat faster to do these procedures asleep rather than awake. With the spinal cord stim especially, there's evidence that you're a little bit more accurate, and that the post-op programming can be a little bit faster if you do this procedure asleep rather than awake. And I think that's related to the fact that patients, particularly with spinal cord stim, if you're prone, lying on face down on the bed, you have back pain, leg pain. As soon as you start to feel some stim, you say, oh, that's good enough, I want to get off the table. And so you don't get the electrode in the optimal position, and so you don't get to test every combination of electrodes. Spinal cord stim, probably one of the oldest treatments we have here. It's well established, lots of indications, and we have leads that go from 8 contact leads up to 32 contact leads from Boston, and I see that they're working on a 64 contact lead, which I think means that if you get it somewhere in the spine, you should be able to stimulate everything. So Dr. Vitali talked about placing the battery in the buttocks. If you have an electrode and a battery from the same company and it's on the buttocks, then you're MI compatible. As soon as you tunnel the lead across the abdomen, the companies don't say it's MRI compatible. And as soon as you mix and match companies, it's not MRI approved. That doesn't mean it's not going to work. It's just that nobody will sign off and say it does work. If you do the awake procedure, this is kind of like this. You sedate the patient. You place the electrode either with an epidural needle, you do a mini laminectomy, you lighten the patient up, and you apply the test stimulation. If the patient feels a stimulation in the region where they have the pain, then you put the patient back sort of slightly more deeper, tunnel the leads, and it's the tunneling which is probably the most painful part of this whole procedure. There's 2 methods for doing this asleep. Chuck Yindlin here, if you look back in history, he was quite a famous actor in New York. He was a Broadway actor back in sort of the 60s, and then he went and said there has to be more to life, and went and got a PhD in neuroscience at San Francisco State, and then became one of the leading neurophysiologists in California. He died of COVID a few years ago, and he looked at, if the idea for spinal cord stim is to block the pain signals, and you should be able to block a sensory evoked potential with the spinal cord stimulation. So he developed the technique where you apply a dermatonal somatosensory evoked potential, and then once you place this epidural electrode, if you have the electrode in the right spot, then you should be able to block it when you turn your stimulation on. Epidural spinal cord stim blocks nearly all somatosensory evoked potentials when you apply it in tonic stimulation mode, which is the mode that was present when he was doing this. It takes a little while to do. So this is a slower procedure than doing it awake, but it was used when patients could not tolerate being awake for their procedure. Subsequently, we came and discovered that there are these things called reflexes, and that if you stimulate the epidural spinal cord, you get a motor response out in the muscles. And Steve Florowski is a neurosurgeon down in the States, and he has pushed really the use of neuromonitoring for neurophysiology, for neurosurgical procedures, and especially for spinal cord stim, and increasingly also for dorsal root ganglion stim. And he's the big advocate for that. And if you look at his publication list, a lot of his publications are around how you do EMG guidance for spinal cord stim, dorsal root ganglion stim. And he has done the big sort of multi-center studies that show that it is faster. And he estimates about a third faster across sort of multiple centers with multiple levels of experience of people doing this. It's about a third faster to do it with the patient asleep and use EMG guidance. We always use EMG guidance. There is a slight chance that patients have a mismatch between where their pain is and where the muscles are corresponding. So you rely on the dermatomes and the myotomes overlapping. In a very small percentage of patients, that doesn't happen. They can be off by one level, but nearly always it does work. Florowski in 2019 showed that there's no change in the accuracy of the final placement. When we tracked how many times we reposition the lead slightly more often with the patient asleep than with the patient awake. And that's probably because the patients, if they're awake, they want to get off the table and say that's good enough. And anecdotally, the nurses tell me that the programming is post-op is a little bit faster. The vagina nurses say it's a lot faster. Saskatoon nurses say it's a little bit faster. Dorsal ganglion stim, very similar to spinal cord stim. If you've got a bit more focal pain, the electrode is placed over the dorsal root ganglion. It's a little bit trickier, I think, to place it out there. We did a little bit of dorsal root ganglion recordings back in my post-op days. And it's a tricky place to get to percutaneously. We do monitor those, and we found from a large series of studies, between 10 and 25% of patients don't have innervation necessarily follows the textbook. So if you think, this patient has L4 pain, you actually want to monitor L3, L4, L5 dorsal root ganglion, just because you may not end up in the same pain distribution. Back when I was doing my PhD, we looked at myotomal innervation. And where a textbook will say a muscle gets innervation from 2 or 3 roots, we found consistently that it gets innervation from about 5 or 6 roots across a wide range of patients, across a wide range of leg muscles. And somebody's repeated that study in the arm and again. Yeah, you get 2 or 3 main root innervations, but most people will have innervation from 5 or 6 nerve roots. For trigeminal pain, as Dr. Vitali said, we have 2 sort of steps. We have a rhizotomy and a stimulation option. The rhizotomy is more of a sort of it wears off after a while. The hope is that when the sort of numbness wears off, the pain doesn't come back, but that doesn't always happen. Sometimes the pain comes back, and you will see that we have some patients who return for 3rd and 4th goes at rhizotomy. Stimulation, we hope, is a little bit more of a long-term therapy. We haven't had anybody come back and say, long-term it's failed yet, but we haven't been doing it really long enough. We do the procedure asleep now. You should put the defib pads on. It seems that Dr. Vitali likes to, is it 1 screen or 2? We've had 2 screens now, haven't we? avasystole. We place needles in all the distributions of the trigeminal nerve, but especially in the painful distribution, and we're increasingly finding that we can guide the electrode into medial or lateral, particularly in V2. Medial lateral is quite a big, there's a bit of a distribution difference between medial and lateral V2. And this has really become feasible because we found a reflex that is present in painful nerves and not present in non-painful nerves. And then we're going to be characterizing this in a bit more detail. We have some work going on over at City Hospital where we're looking at this in a rodent model. We lesion the nerve, and then if we recheck for the presence of the reflex, and if the reflex is still there, we will re-lesion. If the reflex is gone, then we're done, and we move on to either the next distribution or out. The stimulation, very similar to the rhizotomy, and we're still looking for the reflex. As Dr. Vitali said, we're looking for that. We're using that short DBS lead. It's 8 contact leads, and typically we end up with 2 contacts on V1, 3 on V2, and 2 on V2 most of the time, sort of. This is a pretty uncommon procedure in that I think we've done 8 patients out over 2.5 years, and we do close to 80 rhizotomies a year, I think. So it's sort of, 5% of the rhizotomies end up being Gaussian ganglion stimulators. It's typically pretty successful. We have had that one failure. So spinal cord stim, dorsal ganglion stim, rhizotomy, Gaussian ganglion stim, all 3 of those rely on reflexes. The idea is you stimulate a sensory nerve root or sensory nerve, and you record a motor output from a muscle. And from your point of view, if we're going to record a motor output from a muscle, then we need there to be no muscle relaxation on board. So then we start to think about the practical applications. Muscle relaxation, so all of the agents wear off down the body. So when you stick your little probe on the face and you get 4 twitches, that doesn't mean that you'll get 4 twitches in the foot. And at least in my literature, that's fairly well established. We had Dr. Sterling and I saw a classic case of that over the weekend. And it can be a relatively slow progression. So if we're doing a procedure where we want to be able to record a reflex from the lower limb, we might need a lot longer than you say is cleared from the face to be able to get responses down in the foot. The other thing is that not all neuromuscular junctions clear their neuromuscular blockade at the same rate. And so the pharmacokinetics can get into play. So sucks is sort of the one that we think, or the one that people come to me and say, I'm just going to use sucks to paralyze for intubation and you'll be good at the end of this. Well, sucks lasts about 10% of 10 minutes. And sucks is a great agent for intubating because you got nice predictable onset, and you think you're going to have a decent onset. And for many procedures, it does work very well. But the trouble with what we're doing now with many of these neuromod procedures is that we've got pretty fast at it. So 10 minutes, we're often already well into the procedure, particularly in the rhizotomy patients. And when you are testing with your electrical stim, the electrical stim activates the largest axons first. When we're testing with reflexes, we're activating the smallest axons first. So that's the Henneman size principle. And then with electrical stim, you get reverse recruitment. So you recruit the largest axon first and not the smallest. The neuromuscular blocking agent clears from the larger axons, neuromuscular junctions, much more quickly than it clears from the smaller axon neuromuscular junctions. So when you're testing with an electrical stim probe, you may see that all the large axon neuromuscular junctions have been cleared, but the smaller axon neuromuscular junctions can still be completely blocked. ROC has a pretty similar sort of speed of onset as succinylcholine, and then has this wide range. I looked at a few papers as to what is a range of action, length of onset, of duration of onset of rocuronium. 45 to 70 minutes seems like a very wide range. And then you think, well, this is sort of means and averages. So it really isn't that useful for neuromod procedures, apart from the fact that we now have this drug Sugamadex, which can reverse the action of neuromuscular blockade with rocuronium. And Sugammadex is kind of my new wonder drug. It works super fast. It's a couple of circulations of the whole system, and the patient is completely reversed, and we have good reflexes and motor evoked potentials. So my preference then would be to paralyze, if you're going to paralyze with rocuronium and then reverse them for this procedure, rather than use succinylcholine and let it wear off, because I am much more confident in the responses I'm going to get with a longer acting drug that's been reversed than a short acting drug that you can't actively reverse. What for reflexes, and when we're doing that sort of stuff, what anesthesia would we like? This has been very well studied in dorsal rhizotomies, which are used for spasticity. And this is the procedure where I'm going to say to you, please use volatile agent. Usually I come to you and say, Tiva. Actually, if you're going to look for reflexes, volatile is better. There's no clear difference between any of the volatile agents, sevoflurane, desflurane, even isoflurane. They all are about the same. It's typically best if you can avoid ketamine. Ketamine does some funny things to the motor end plates. And then why am I saying that spinal cord stim, we're looking at it, is a reflex? If you place the electrode anything other than exactly midline, and most of the time we're close to midline, but probably not exactly physiological midline because it's a very small target, the activation occurs out on the dorsal root entry zone rather than in the epidurals, on sort of the dorsal columns itself. And so you're activating neurons that project into the dorsal columns, and then so you're effectively getting what is in effect an H reflex. And I was talking to the Pittsburgh group over the week, and they've been able to show very nicely that with electrodes 2 millimeters off midline, they are definitely getting H reflexes and not activating the dorsal columns directly, but activating dorsal columns through the H reflex. Is spinal cord stim cost effective? If you have a single payer system where both the drugs that the patient is taking to manage their pain and the implants are covered by the same system, then it's very clearly yes. Interestingly, if you look at the UK National Health System, where they subsidize pharmaceuticals and they pay for the implant, yes. Or if you look at the US system, where United Healthcare pays for your drugs and pays for your implant, then yes. Canada's a little bit unusual in that Saskatchewan Health will pay for your implant and your private insurance payer will pay for your drugs. So the tracking the cost gets a little bit more complicated. But there's 3 papers from the last 18 months using modern SCS pulse generators. So this is either using tonic, burst, high frequency, any of those stimulators which are now out. They all say it's pretty cost effective and breaks even in a few years. Kumar and Rizvi is a Sask paper from now 12 years ago. K. Kumar died shortly after this paper. Saeed Rizvi is now a neurologist down in Regina. The batteries cost about $20,000, give or take, ish. And typically the companies say the rechargeables last 7 to 12 years. I think that's probably about accurate. The non-rechargeables last obviously a little bit less and are consequently a little bit cheaper. We're mainly implanting rechargeable batteries now, aren't we? Yeah. Another thing that you're going to see more and more of, probably at least in the media, is SCS for restoration of leg function after spinal cord injury. Some of you will remember this guy. He went to Thailand to get his spinal cord stim implanted after his paraplegia in the Humboldt Broncos crash, so we can say who he is because he made a big media splash about it. This is Grégoire Courtine, who would be my bet for probably one of the Nobel Prize in the next 15 years for his work here. He's developed and has implemented in Switzerland this closed loop spinal cord stim EEG controlled system for getting paraplegics to walk. And it's really quite impressive. So this is, he has an ECOG system implanted over the brain, spinal cord system, and then a battery backpack that does all the processing in the middle. And these patients actually do get up and walk. It's probably a slightly complicated slide, but it shows that they are able to walk in a reasonably good way.
We designed a system that could be operated by the participant without any assistance. This system includes a walker equipped with an integrated case that embeds all the components of the brain-spine interface.
Is there a way to mute this? Maybe not.
A tactile-based interface allows him to interact with the software to launch a...
Oh, well, we'll skip it. The other thing might be spinal cord stim for restoring sensation in amputees. So Dr. Vitali said it doesn't work great for post-amputation pain. It's a sort of moderately successful. But then there's a couple of recent studies shown that you can reduce the fall rate by close to 80% by if you give them some sensory feedback, so that when they put their prosthesis down on the ground, they get feedback as to how hard they're putting their prosthesis down on the ground. And this was work that was led by Ashley Dalrymple. Most of you won't know who Ashley is, but many of you might know Ashley's husband, who's John Staples, the pediatric plastic surgeon. And she's in Utah. She's coming to give us a talk on that in December to the amputee group. PT has a fairly strong amputee rehab group, so she's coming to talk to them about that. And then Doug Weber here he's in Pittsburgh. His wife is from just north of Saskatoon. He and I were postdocs in Edmonton together, but he's been using it to look at treatment of autonomic dysreflexia in spinal cord injury patients. Moving on to deep brain stimulation, it's widely accepted treatment for movement disorders. There's very good evidence it works for epilepsy, emergent evidence it works for mood disorders, a bit of pain. We've done a couple of pain patients down in Regina. Some evidence emerging that it works for altered levels of consciousness. Typically, we think of this in three phases. There's a planning phase, there's a place in the brain electrode phase, and then there's a tunnel in the wires, a place in the batteries. Historically, the first two blue phases were done with the patient awake. The planning phase can be relatively long. In Saskatoon, we're fortunate in that we bring the O-arm into the operating room, and so we fix the patient in bed, do the O-arm scan, and then do the final stage of the planning there. In Regina, the patient goes down to the CT scan and comes back up. So there's this sort of phase where the patient's walking around, being pushed around the hospital with their head in a stereotactic frame, which is interesting. The awake portion can be anywhere between 4 and 7 hours. I talk to the people around the country. 4 hours is pretty much on the short end. People in Calgary are taking in excess of 10 hours sometimes to do some of the awake stages, and the head is fixed to the bed. And if you think about as I said, an elderly patient with Parkinson's disease who's in their 60s, 70s, bit of neck pain, bit of back pain, bit of hip pain, that's not always the most pleasant thing. So we've been moving to do this asleep. The patient was already going to get an anesthetic because the final stage of placing the battery and tunneling the wires was done under anesthetic. So they were always going to get an anesthetic. It's a relatively long period of time when we don't actually need the patient awake. So the planning, the scanning, drilling a hole in the head, the patient doesn't need to be awake and cooperative. So the time when we needed the patient awake was probably about 5 minutes per side. So it's a lot of asking the patient to be awake for sort of 10 minutes of stuff. The procedures do seem to be faster. We can do very good recordings. We can't test the stimulation. Apart from the new tests we've come up with for testing VIM, for testing speech mapping. There's good evidence it reduces the incidence of air emboli, probably because patients don't cough and move around so much. And we've sort of done it for a long time for patients with dystonia, particularly cervical dystonia. Here's my preferred cocktail. About sort of propofol Remy plus or minus some blood pressure support, depending on what the patient requires. When you come and ask me what I want, for most things, when you come and ask me what I want stability. Set up your anesthetic and step away from the machine. So if you have a stable anesthetic, we can usually make the recordings work. Applies across pretty much everything you do. If you're changing the anesthetic for reasons sort of other than sort of blood pressure support, if you're having to turn your propofol up or down or anything like that, it's going to make it a lot harder for us to get good quality recordings. The nice thing with these procedures is there's a very long time between the time you put the patient to sleep and the time I need to do my recording. So even sort of as fast as we are, it's still probably 2.5, 3 hours between the patient going to sleep and getting the recording started. Can you still record from the thalamus? When I started doing this, the idea was you couldn't record from thalamic neurons with the patient asleep. Now we've got much better at having stable anesthetic, and we've also got much better quality electronics. And yes, you can record from the thalamus. So here's a sort of a sample trace. Here's the firing frequency of a group of cells in the thalamus. Baseline with, this is all with the patient asleep. The blue is the baseline. If we need to turn up and increase the excitability of the thalamus, we can stick in some SSEP type stimulating electrodes or just some sticky electrodes down at the wrist and then stimulate the thalamus. So you just get a little bit of movement on either side, and we increase the excitability of the thalamus quite nicely. This was another project where we're looking at how you can randomly activate the thalamus as well. Recent advances. One of the things that's helped us with this is that all the companies now in Canada have these directional leads. So we can, even when we place the lead and we have it, we can then start to steer the current post-op in the programming. So instead of having a circular field of current that just expands, we can send it out through sort of one of three directions. So there are about 100-ish degrees of current that you can spread it out into. And then there's a few degrees of blocked. The Medtronic system allows us to chronically record the local field potential. And that's probably going to lead to closed loop control of DBS in the future with that company. And then there's a new company on the market that has cranial fixation of the battery, so you don't have to do the tunneling down the wire. That's not available in Canada yet. That's available in Europe. And the other thing that is going to come in at some point, I suspect, is closed loop stimulation for epilepsy through the company is called NeuroPace that has their system. They have an epidural electrode placed over the temporal or the epileptic foci, which is typically the temporal lobe. And then they have a sort of a deep brain stimulation electrode placed as well. And then they have a cranial mounting for the battery and the controller. It's widely used in the States. There's been sick kids have done a couple. I think Western did a couple. I may be able to clarify. There's some technical and administrative questions because all the data is automatically sent back to their server in the States. So you need to have some issues resolved about transporting patient data across the border. It's not clear quite how this is working because the controller, when you look at their data, the patient's having way more seizures than are ever reported by the epileptologist. The other thing I was going to say, just any patient with an implanted neurostimulation device may require special considerations for subsequent surgeries. So these patients, as they get older, they come for other things. So they go and see one of the orthopods for arthroplasty or something. Not all the devices need to be turned off for surgery, and most of the modern devices have a surgical mode, and you can just switch the patient into surgical mode. It's often the same mode. The surgical mode and flight mode are often the same, and may also be MRI mode, but they do often will need to be turned into that mode, and you should use, the surgeon should know this, but they should be using plasma blade rather than regular monopolar if they're reoperating on a patient who has a implanted device and they're close to that.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.